Hello everyone. We are going to discuss regarding a very important and a common valvular heart disease, mitral regurgitation. Okay, so the topic of discussion is mitral regurgitation. So, in the due course of this discussion, we're going to start off with the basics about mitral regurgitation. Then we'll proceed ahead with the etiologies of MR, then the hemodynamics of MR, moving on to the clinical features of mitral regurgitation, the evaluation part, and finally the management of mitral regurgitation. So that's how we are going to discuss this module. Let's start off with the very basics about mitral regurgitation. So remember, I have already made a statement that MR is one of the most common valvular heart disease. And if you ask me, so what causes mitral regurgitation? My simple answer will be MR occurs because of a dysfunctional mitral valve apparatus. Okay, a dysfunctional mitral valve apparatus. Okay, dysfunctional mitral valve apparatus. Now remember, I made a statement, dysfunctional mitral valve apparatus. I just did not say mitral valve, I'm talking about an apparatus. So let's try to understand what is this apparatus. Well, mitral valve apparatus is a complex structure, and this structure or this apparatus has 5 functional components. So let's try to see what are the functional components of the apparatus. Number 1, you have mitral leaflets. Okay, you have mitral leaflets. Okay, mitral leaflets. Number 2, you have mitral annulus. You have mitral annulus. Number 3, chordae tendineae. Okay, you have chordae tendineae. Number 4, the papillary muscles. The papillary muscles. And number 5, the adjacent myocardium. Adjacent myocardium. So when I say adjacent myocardium, I mean the supporting wall of the left ventricle. Okay, the supporting wall of the left ventricle, and together all these structures, okay, together will form the mitral valve apparatus. Okay, so I think you've got a basic idea of what I am talking about. Now things will be a lot clear when you have a look at the mitral valve apparatus image. So just go through this. You can see the leaflets, the anterior leaflet as well as the posterior leaflet. You can see the mitral annulus, the anterior annulus and the posterior annulus. You can see the chordae tendineae. You can see the papillary muscles, the medial and lateral papillary muscles. And you also have the supporting wall of the left ventricle. So all this will together form this mitral valve apparatus. So I can make a simple statement that mitral valve apparatus is a complex structure that consists of 2 leaflets which are being attached to the left atrium by the mitral annulus and to the left ventricle via the chordae tendineae and the papillary muscles. Okay. So you've got an understanding on the mitral valve apparatus and MR, which occurs because of a dysfunctional mitral valve apparatus. So now that the basics are clear, let's proceed ahead with the etiologies of mitral regurgitation. Okay, we are going to discuss etiologies of MR. Okay, very important. Let's discuss etiologies of MR. So etiologies of MR, well, this is very, very important. First of all, I can divide this into acute mitral regurgitation, okay, acute mitral regurgitation, and also chronic MR, okay, chronic mitral regurgitation. So that's how I'll divide it. So first of all, let's have a look at the etiologies of acute MR. So acute MR occurs because of varied etiologies like number one, infective endocarditis. So in infective endocarditis, you can have a destruction or perforation of the valve leaflets leading on to an acute mitral regurgitation. Then you can have acute myocardial infarction. Okay, you can have an acute MI as an etiology of an acute MR, mostly because of the rupture of the papillary muscles. Even you can have a blunt trauma leading on to acute MR. Okay, you can have a blunt trauma leading on to acute MR. Now, one MCQ you should know, which is given in Harrison also, so high likelihood of being asked. See, when it comes to an acute mitral regurgitation, remember that the posteromedial papillary muscle is more involved than the anterolateral papillary muscle. So this primarily is going to involve the posteromedial papillary muscle. Okay, this is going to involve the posteromedial papillary muscle. Now, if you ask me what is the exact reason for this, remember the anterolateral papillary muscle is supplied by both the left anterior descending and the circumflex arteries, whereas the posteromedial papillary muscle that we are talking about is supplied only by the right coronary artery. So I can say that the posteromedial papillary muscle has a singular blood supply. Okay, this has a singular blood supply. So single source from the right coronary artery, which means this is more susceptible. Okay, so that point is very, very important. Now let's try to discuss about chronic mitral regurgitation. Okay, so we have seen about acute mitral regurgitation. Let's discuss chronic mitral regurgitation. So chronic mitral regurgitation, you can again subdivide into two. One is the primary chronic mitral regurgitation and next is secondary chronic mitral regurgitation. Primary and secondary. So primary MR is also referred to as organic or degenerative MR. Organic or degenerative MR. Whereas secondary MR is functional MR. So what is the basic difference between these two entities? See, when you talk of primary MR, the defect is or the dysfunction is because of a leaflet or chordae tendineae affection. So in organic MR, you are having either the affection of leaflets or the chordae tendineae. Okay. So either the leaflets or the chordae tendineae is being affected, whereas in case of secondary or functional MR, the leaflets and chordae tendineae are normal. This is very important. So in functional MR, the leaflets and chordae tendineae are normal, and the problem is with the left ventricle, okay, is with the LV or the mitral annulus, okay. The problem is with the LV or the mitral annulus. So this differentiation is very, very important between primary MR and secondary MR, which are subtypes of chronic MR. Primary MR, leaflets or chordae tendineae. Secondary MR, leaflets, chordae tendineae normal. The diseases of the left ventricle or the mitral annulus. So when it comes to a secondary mitral regurgitation, the reason for the regurgitation is I told you left ventricle affection. So what happens is there is a remodeling of the left ventricle. So there is a LV remodeling, okay, LV remodeling, and also you can have an annular dilatation, okay. So because of the LV remodeling as well as annular dilation, that's why you are having this functional MR. Now, how important is to differentiate a primary versus a secondary chronic MR? Yes, it is important because the treatment and long-term prognosis can differ significantly between primary and secondary MR. which is why this is very important to differentiate. So that's the broad division: acute, chronic, chronic again, primary, secondary. Now let's have a look at this table from Harrison on the major causes of mitral regurgitation. You can see they have subdivided into acute and chronic. The acute causes we have already seen: infective endocarditis, papillary muscle rupture, chordae rupture, blunt trauma. And chronic, again, you have primary as well as secondary. So let's have a quick look at the varied etiologies of chronic MR, just the basics. Now you see here, when it comes to a primary chronic MR, the most common cause of a primary MR will be a myxomatous degeneration of the mitral valve leaflets, and such sort of a myxomatous degeneration can lead on to a mitral valve prolapse. Okay, can lead on to a mitral valve prolapse. Okay, very clear. Now, what happens is when you have a myxomatous degeneration, tell me what will happen to the tensile strength of the mitral valve? Obviously, the tensile strength reduces. When the tensile strength reduces, the otherwise compact mitral valve will have a tendency to prolapse into the left atrium. Okay, will have a tendency to prolapse into the left atrium. So which is why myxomatous mitral valve degeneration is an important cause of mitral regurgitation. Now talking about rheumatic fever, yes, rheumatic fever can cause, say, deformity, rigidity of the mitral valve cusp. And also in the mitral valve apparatus, you have the commissures. You can have a commissural fusion as well. And about the chordae tendineae, you can have a shortening of the chordae tendineae. You can have a fusion of the chordae tendineae. You can have a contraction of the chordae tendineae. So again, it goes to show that the apparatus is getting distorted. The mitral valve apparatus is getting distorted. Infective endocarditis, I told you, even it can cause acute MR. So remember, it can lead on to chronic MR as well, because see, it can perforate the mitral valve leaflets as well as cause valve deformities. It can cause vegetations in the valve. It can even cause the rupture of the chordae tendineae. All this can lead on to a mitral regurgitation. Now, what about congenital causes? Yes, mitral valve regurgitation can occur as a congenital anomaly, and that often occurs because of a defect of the endocardial cushions. Okay, it occurs because of a defect of endocardial cushion. Okay, endocardial cushion. And also it can occur as an association with a cleft anterior mitral leaflets. Okay, cleft anterior mitral leaflets. Okay, and even radiation also can lead on to thickening and retraction and even calcification of the valve leaflets. So these are some important causes of the primary mitral regurgitation. Now coming to secondary MR, see, you can have either ischemic or non-ischemic cardiomyopathy leading on to a mitral regurgitation. So talking of an ischemic cardiomyopathy, let's consider the case of a myocardial infarction. So in case of a myocardial infarction, there occurs a change in the structural architecture of the left ventricle. You can say that the LV size, shape, and even function is affected. Or basically, I can sum up that there is a ventricular remodeling in mitral regurgitation. So it's like an ischemic DCM, ischemic cardiomyopathy occurring. So even in case of a non-ischemic dilated cardiomyopathy, because see, myocardial infarction leading on to a dilated cardiomyopathy is a ischemic DCM. You can have genetic causes of dilated cardiomyopathy as well. And remember, even in the genetic or the non-ischemic causes of DCM, you can have a ventricular remodeling, your annulus getting distorted, the annulus getting dilated, and there is a mitral regurgitation. And coming to hypertrophic obstructive cardiomyopathy, well, in case of HOCM also, you're going to have a dynamic mitral regurgitation. You're going to have a dynamic mitral regurgitation. So this dynamic mitral regurgitation is dependent on what? SAM. What is SAM? The systolic anterior motion of the anterior mitral valve leaflet is occurring into a narrowed left ventricular outflow tract. So because of this, I've already discussed this in the module on hypertrophic cardiomyopathy. Because of that, you can have a dynamic mitral regurgitation. And what about atrial fibrillation? Well, atrial fibrillation can lead on to atrial remodeling and annular dilatation. And this can also lead on to a functional MR. I told you predominantly it's a LV problem, but even atrial affection also can lead on to a mitral regurgitation. So AF with a LA enlargement and annular dilatation can lead on to a atrial functional MR. And finally, coming to mitral annular calcification, MAC. So mitral annular calcification, remember the calcification of the annulus, especially when it encroaches into the leaflets, can result in mitral regurgitation. And this predominantly is a finding in case of older adults. Okay, this predominantly is a finding in case of older adults. So remember, the mitral regurgitation associated with a mitral annular calcification is usually a moderate MR. It's not usually very severe. Okay, it's a moderate MR. And let's just have a look at the varied etiologies of the mitral regurgitation. You can see a normal mitral valve. You can see the myxomatous degeneration and prolapse of the mitral valve into the LA. You can see a ruptured chordae tendineae leading on to mitral regurgitation, and even annular dilatation also can lead on to regurgitation. And also you can subdivide the varied causes of the chronic MR based on which structure of the mitral valve apparatus is being predominantly affected. Is it the leaflet? Is it the chordae tendineae? Is it the papillary muscles? And also it can occur as a part of the prosthetic valve. Yeah, I forgot to mention about mitral annulus as well. It can also occur as a part of the prosthetic valve. So varied etiologies, they can affect varied components of the mitral valve apparatus. But remember, the same disease can affect more than one component of the apparatus. For example, if you take a connective tissue disorder. So connective tissue disorders can affect the leaflets as well as the mitral annulus. Whereas certain disorders are primarily involving, say, the leaflets, like a degenerative mitral valve disease. So that also you should remember. So we have had a detailed look at the varied etiologies of MR, the acute MR, the primary and secondary MR. Now there is one additional point that is mentioned in Braunwald, is about the causes of MR being categorized by the type of leaflet motion abnormality. So there is a classification system that is proposed by Carpentier, and the Carpentier classification is based on the type of leaflet motion abnormality. You're classifying this into type 1, type 2 and type 3. Type 3 classified into 3A and 3B. So what are these Carpentier classes? Well, when it comes to the leaflet motion, in type 1 you will have normal leaflet motion. Okay, you will have a normal leaflet motion, whereas the leaflet motion is increased in case of type 2. And when it comes to type 3, in case of type 3A, there is a restricted opening, and in case of type 3B, there is a restricted closure. Okay, restricted opening of the valve leaflet, and this is a restricted closure. Okay, this is the Carpentier classification. So how important is this Carpentier classification? Well, let me just show you this table also from Braunwald. You can see the type 1, type 2, type 3A and type 3B. You can see the ventricular view as well as the atrial view of the mitral valve leaflets in these various types. Now remember, the type 2, okay, the type 2 and type 3A. Okay, type 2 and type 3A. Now, what is common to these two types is that both these two types are primary disorders of the valve leaflets. Okay, they are primary disorders of valve leaflets, primary disorder of valve leaflets, whereas type 1 and type 3B, they have relatively normal valve leaflets. However, there is a distortion of the LV as well as annular remodeling. So because of which type 1 as well as type 3B, you will have a secondary mitral regurgitation that occurs in association with these two types. Now, how is the Carpentier classification useful? Because these mechanisms can help you strategize the surgical correction of mitral regurgitation, which is why a proper understanding of the Carpentier classes are important. So we have had a discussion on the classification of the etiologies of mitral regurgitation. Okay. So after having discussed the varied etiologies of mitral regurgitation, let us proceed ahead and discuss the hemodynamic changes associated with mitral regurgitation. Okay. Let us discuss about the hemodynamic changes. Okay. Now coming to the hemodynamic changes, we are going to have a closer look at the pathophysiology of mitral regurgitation. Now we'll start off by comparing the normal hemodynamics versus the hemodynamics in case of acute mitral regurgitation. Yes, we will proceed ahead and discuss chronic mitral regurgitation also, but let's start off with acute MR. See, in case of an acute mitral regurgitation, take for example, the patient had a infective endocarditis and there was a rupture of the chordae tendineae. So that resulted in an acute MR. See, what will happen during the acute MR is that during the LV systole, okay, during the LV systole, what will happen is the mitral valve leaflet will bulge into the left atrium. So the mitral valve leaflet bulges into the left atrium, and because of which, in addition to the forward flow from the LV to the aorta, you can also have a backward flow into the left atrium, correct? So in normal state, from the LA to LV, you are having the forward flow. So, but here what happens is that in addition, there is a reverse or a backward flow happening, correct? So in addition to the forward flow, yes, there is a forward flow to the aorta, but there is also a backward flow into the left atrium. Now, because there is a backward flow into the left atrium, what will result is that the left atrial pressure and volume will increase. Okay, the LA pressure and volume will show an increase, correct? Now the volume of this regurgitant jet of blood from the LV to the LA obviously will depend upon the size of the regurgitant orifice and also the pressure gradient between the two chambers. The two chambers in this case are the LV and the LA. So because of the backward flow, I'm sure you will agree with me that the forward stroke volume will fall. Okay, the forward stroke volume will fall because the LA pressure and volume will increase. What happens is that the LVEDP, that is the left ventricular end diastolic pressure, this will increase during diastole. Now, why does LVEDP increase during diastole is because, see, more blood within the atria, when there is a volume overload in the atria, obviously more blood will come to the ventricles as well. So what happens in case of an acute MR is an acute volume overload of LA and LV. Okay, so there is an acute volume overload of the LA and LV. Now this is very, very important. Now if you compare the stroke volume, okay, in normal case versus the acute MR, you must understand one thing, that since the end diastolic volume is increased in acute MR, obviously because of more blood coming into the LV, we have all heard of the Frank stalling mechanism. Yes, you have heard of the Frank stalling mechanism. Okay, Frank stalling mechanism. So Frank stalling mechanism says that the force of contraction is proportional to the end diastolic volume. So when the end diastolic volume increases, what will happen? The force of contraction increases. Now because of the Frank stalling mechanism, it is easy to understand that the total stroke volume, listen to this term, total stroke volume in case of an acute MR will increase. Okay, I said total stroke volume. Now what is this total stroke volume? It is the sum total of the forward stroke volume that goes to the aorta plus the regurgitant volume of blood that goes into the LA. So though the total stroke volume increases, the forward stroke volume is subnormal, or there is a decrease in the forward stroke volume. And because there is a decrease in the forward stroke volume and there is a significant regurgitant jet of blood, what is the threat in case of an acute MR? The threat is that of an acute pulmonary edema. The threat is that of an acute pulmonary edema. Okay, so patient can develop a acute pulmonary edema. So remember, in this stage of acute MR, the patient is developing a heart failure despite the normal LV contractility. Okay, so the cardiac output is less, but this is with a normal LV contraction because see, the LA is not able to adopt. It's a quick developing acute MR and the LA is not able to adapt. Pressure is transmitted back and there is an acute pulmonary edema. So I hope you are clear with the hemodynamic changes in case of a acute MR. So having seen the acute MR, let's just have a quick look at the figure as well. You look here, this is the forward stroke volume in the normal case. And you see in an acute MR, there is a reduction in the forward stroke volume. And you can see that there is a regurgitant jet of blood also going into the LA. So from the LV, there is a regurgitant jet of blood into the LA. But remember, the total stroke volume, if you add the forward and the backward, that is more than that of the normal state. Okay, I hope that is very, very clear for you. Now let's proceed ahead and let's discuss about chronic compensated mitral regurgitation. Okay, so we have done with the hemodynamics of acute MR. Let's see about chronic compensated MR, which means we will definitely be discussing chronic decompensated MR as well. See, in many cases, when the patient develops a severe acute mitral regurgitation, this might require a surgical correction, okay, for the patient. But suppose you are able to tide over the acute phase, you are managing the patient symptomatically, or you assume another case where it is an insidiously developing mitral regurgitation as a part of a degenerative valve disease. So what can happen is, or even say a rheumatic heart disease where it is developing slowly. So here the valve abnormalities develop very slowly. And there is a phase of a hemodynamic compensation. The body is trying to compensate. So what I am going to talk to you is about a stage of hemodynamic compensation. Okay, a stage of hemodynamic compensation. Okay, all right. Now, when I talk of hemodynamic compensation, what is your body trying to do? You know what? The goals that your body is trying to achieve via the compensation, one goal is to improve the forward cardiac output. Forward cardiac output. Okay, improve the forward cardiac output. And the second goal is that you have to reduce the pulmonary congestion or to avoid the pulmonary congestion. Okay. All right. So this is the goal. Now, in case of a chronic compensated MR, how does the compensation happen? See, the major change when it evolves from a stage of acute MR to a chronic MR, that evolution is basically the evolution of the LV or the left ventricle in response to the hemodynamic changes. So what I'm trying to tell you is that there is an enlargement of the left ventricle that happens during this phase so that the patient goes into a hemodynamic steady state. Now let us imagine a case of a acute MR. Okay, a case of an acute MR. So in case of an acute MR, what about the size of the left ventricle? Though there is a volume overload, you can say that the LV is otherwise a normal sized hyperkinetic left ventricle. Okay, the size is normal sized but hyperkinetic. LV is what you see in acute MR. Okay, acute MR. Correct. Now, when it goes to the stage of a chronic mitral regurgitation, what can happen is that this is converted to a large compliant chamber. Which one? So, the LV is being converted to a large compliant chamber. Okay, it is being converted to a large compliant chamber. Okay, so that the chamber is suited to deliver a larger stroke volume. Because see, I told you one of the goals of the body by hemodynamic compensation is to improve the forward cardiac output. So somehow the left ventricle has to remodel itself so that it can deliver a larger stroke volume. Now, how does this remodeling happen is via the some rearrangement that occurs in the myocardial fibers. There occurs addition of new sarcomeres. So via this, there is a LV remodeling that takes place. Okay, there is a LV remodeling that takes place. Okay, and it's easy to assume that the response to the heart in response to the valvular lesion, that is MR, is pretty different in acute and chronic. So in case of chronic, when you have a regurgitant jet and there is a LA also trying to adapt, there will be a LA dilatation. Okay, so in case of a chronic MR, remember acute MR, the LA did not get any time to adapt. But in case of a chronic MR, there occurs a LA dilatation. Okay, there occurs a LA dilatation. So when the LA dilates, the LA compliance is increasing, and tell me, when such a compliance increases, what will happen to the LA pressure? Well, what happens is that the LA pressure, which otherwise would have been very high, via the enlargement, it somehow reduces the LA pressure despite the larger volume of blood in the LA, because it is trying to compensate. So if you compare the pulmonary capillary wedge pressure in case of a chronic MR and acute MR, the pulmonary capillary wedge pressure will be less in case of a chronic MR in comparison to an acute MR. Okay. So because there is a decreased LA pressure, now this is very, very important, listen carefully. Because the LA pressure decreases, the pressure gradient across LA and LV is more. Correct? Because LA is at a very lower pressure. So in comparison to the acute MR, the regurgitant fraction will be more in case of a chronic MR. Now let's try to understand that once again. because in acute MR, the LA was not adapting. So though there was a volume overload, there was a higher pressure in the LA itself. So the pressure difference is one important factor that will determine the amount of the regurgitant jet. In case of a chronic MR, since the LA has got time to adapt, what will happen is that the LA is at a lower pressure. So the pressure gradient LV minus LA will be more. Hence, you will have a increased regurgitant fraction. Okay, so there is a increase in the regurgitant fraction in case of which one? In case of your chronic MR. Increase in the regurgitant fraction. Okay, all right. So what I am trying to tell you is that in chronic MR, you are having an increased atrial compliance, and the increased atrial compliance will reduce the pulmonary congestion and edema. So if you compare with the acute MR, in case of a chronic MR, there is a reduced chance for pulmonary congestion and edema. Okay, reduced chance for a pulmonary congestion and edema. Okay, and because the LV also dilates, okay, because the LV also dilates, because I told you there is a LV remodeling and there is an eccentric hypertrophy. What sort of hypertrophy? Eccentric hypertrophy, that is involving the left ventricle. So since there is an eccentric hypertrophy involving the left ventricle, there is a LA dilatation also. And this LA dilatation will reduce the left ventricular end diastolic pressure in comparison to an acute MR. So what I'm trying to tell you is that a compensatory dilatation of both LA and LV occurs in a chronic MR. And what is the purpose of this compensatory dilatation is to accommodate a volume overload at a lower pressure. And since it accommodates the volume overload at a lower pressure, it will help to relieve the pulmonary congestion. Clear? Okay, so let's have a look at a comparison between normalcy, acute MR and chronic MR. You can see most importantly, it's the LA size and LV size that increases in a chronic stage in comparison to an acute MR. This is very, very important to understand. Okay. So I hope you are very clear with chronic compensated MR hemodynamics. Let's just quickly have a look at the image. You can see here. So there is a forward stroke volume, which is again near normal. Okay, the other one was 100 ml. This is again 95 ml. So it is trying to compensate. There is a backward flow, but you see the LA pressure. It is 15 millimeter mercury. You compare with the LA pressure in an acute mitral regurgitation where the LA was at a higher pressure. Okay, but the regurgitant fraction will be more in case of a chronic compensated MR. But though there is an increased regurgitant fraction, since the LA has expanded, LA is ready to receive more blood. What will happen is that, there is more regurgitant fraction, but still there is not much of a pulmonary congestion and edema. Okay, that's clear. Now let's move on to the chronic decompensated mitral regurgitation, chronic decompensated MR. So see, from a stage of compensation to a stage of decompensation, how does it proceed? Remember, for long years, you can have the mitral regurgitation being tolerated by the body, but in due course of time, the left ventricle has undergone some remodeling. So there will be some sort of a LV dysfunction, correct? There will be some sort of an LV dysfunction. You can have development of arrhythmias. You can have development of heart failures. So within 5 years of say a severe MR, many of the cases can proceed on to a decompensated stage. So in the decompensated stage, what will happen is, see, the ventricle has had some damage. That is the bottom line. So there is a damage that has occurred in the ventricle in simple layman terms. So whenever there is a damage to the ventricle, what will happen to the ejection fraction? It will decrease. So there is a decrease in the ejection fraction. Okay. And what will happen to the end systolic volume? because the ventricle is not able to pump properly, the end systolic volume will increase. The ESV or the end systolic volume will increase. Correct? So what will happen is there is a higher LV systolic volume. The LV is not able to pump. So at the end of systole, the residual volume in the LV will be higher or lower? It will be higher. So there will be a higher LV residual volume at the end of diastole, and this will increase the EDV, end diastolic volume, and end diastolic pressure. So when it increases the end diastolic volume and the end diastolic pressure, again the patient is likely to develop pulmonary congestion. Okay, so he can develop pulmonary congestion and edema. So that is again a threat in case of a chronic decompensated MR. So you can see the forward flow is decreased. You can see the end systolic volume is increasing, and there is a regurgitant jet from the LV to LA. Okay, and you can see again the LA pressure is increasing, which is transmitted back, and there is a pulmonary congestion and pulmonary edema. Please also understand that as the disease progresses, there is an LV dilatation that is happening, and this per se, LV dilatation per se can increase the amount of regurgitation, because when the LV dilates, the mitral annulus also dilates, and also there is a distortion of papillary muscles as well. So what I want to tell you is that you can also make a statement like MR begets MR. Okay, MR begets MR, because what started off as MR, in due course of time, when the LV dilates, when the annulus dilates, regurgitant fraction increases, so MR again worsens, which is why you can say MR begets MR. So it's very important to have an idea on the hemodynamics of an acute MR, the chronic compensated MR, and a chronic decompensated MR, because it is based on this that the patient develops these symptoms, and you have got to have a solid idea on this topic. Okay. All right. Now let's come to the clinical features of mitral regurgitation. To begin with, let's have a look at the symptoms. Okay. So what are the common symptoms in a patient with mitral regurgitation? So coming to the symptoms of mitral regurgitation, the symptoms will depend on multiple factors. We just had a discussion on the varied stages of mitral regurgitation: acute, chronic compensated, chronic decompensated. So obviously the symptoms will depend on the stage of mitral regurgitation. It will depend on the severity of mitral regurgitation. Okay, and it will also depend on the rate of progression of the disease. Okay, rate of progression. Okay, and the other factors on which the symptoms will depend are the pulmonary artery pressure, pulmonary artery pressure. It will also depend on the presence of arrhythmias, because I told you already that you can have certain arrhythmias like atrial fibrillation, which can develop in the context of a mitral regurgitation. And when you have development of such arrhythmias, yes, you will have features of those arrhythmias, maybe palpitations, plus you can have features of decompensation as well. And also the symptoms will depend on if the patient has any other associated cardiac disease. Okay, if he has any other associated cardiac disease. So the symptoms will depend on all these factors. Now remember, suppose if a patient has a chronic mild to moderate isolated MR. Okay, so suppose if a patient has chronic mild to moderate isolated MR. Okay, mild to moderate isolated mitral regurgitation. See, in such a case, many a times the patient is asymptomatic. Okay, many a times the patient is asymptomatic. right? So patient is usually asymptomatic, goes to show that the LV overload or the LV volume overload, what is there, is pretty much tolerated by the patient. And in many of the cases where the mitral regurgitation occurs as a sequelae to myxomatous degeneration and subsequent MVP, that is a MVP MR. So even a MVP MR, many cases are asymptomatic. Patient may remain totally asymptomatic throughout life even. Okay. So you can have MVP MR being symptomatic as well, but I'm just saying that you can have a subset of patients with MVP MR who are asymptomatic. Now, when the patient goes on to develop a chronic severe MR, that is when the symptoms becomes more obvious. See, even in the mild to moderate isolated MR, there can be some symptoms, but mostly non-specific. There might be some fatigue, so might not be noticed by the patient, or he might attribute to something else. So it is when the patient goes to a stage of chronic severe MR, he goes on to have more significant fatigue. Okay, he might develop a exertional breathlessness. He develops exertional breathlessness, and he can go on to develop symptoms like orthopnea. Okay, he can go on to develop symptoms like orthopnea. See, why do these symptoms develop? Fatigue, exertional breathlessness, orthopnea. Why do these symptoms develop? Is basically because of the hemodynamic changes that I've already taught you, that there is a decreased forward cardiac output. Okay, so there is a decrease in the forward cardiac output, or even I can say there is a decrease in the effective cardiac output, and there is an increase in the LA pressure because of the backflow across the mitral valve. So the patient can develop various symptoms. So these are some of the symptoms to start off with, and then if the patient develops atrial fibrillation, as I said earlier, the patient can have a palpitation. And especially in a stage of acute mitral regurgitation, as well as chronic decompensated MR, in these two phases, patient can go on to develop a acute pulmonary edema. Okay, patient can go on to develop a acute pulmonary edema. Okay, and patient can also develop features of right-sided heart failure. Okay, because predominantly it's left-sided heart failure, but you can also develop features of right-sided heart failure as the disease progresses. So patient can have features like a congestive hepatomegaly. You can have edema, ascites. So congestive hepatomegaly, edema, ascites. You can have features of right-sided heart failure. So right-sided heart failure often happens in the context of an acute MR or maybe a decompensated mitral regurgitation. So it commonly sets in when you have a pulmonary hypertension and there is a elevated pulmonary vascular resistance. So always remember, when you have patients with a severe MR and an LV enlargement, always be worried of development of heart failure. So either during the stage of an acute MR or a chronic decompensated MR. So remember, once the patient develops a progressive MR and you have a significant LV dilatation, then whatever myocardial dysfunction has happened is mostly irreversible. Okay, so please keep in mind that point also. Now, in addition to the symptoms which I have mentioned, remember that the patient also can have certain symptoms which may be related to the etiology of MR. For example, if the patient has a infective endocarditis, if the patient is having a connective tissue disease like SLE, if the patient is having Marfan syndrome. So in these cases, you can have specific symptoms of the disease or syndrome in addition to all the features which I have already mentioned. Okay, so these are the symptoms in case of mitral regurgitation. Okay, I hope that is clear for you. Now let's move on to the examination findings. Okay, what are the examination findings in patients with mitral regurgitation? Okay, examination findings. So examination findings in MR, let's start off with the arterial pulse. Okay, let's start off with the arterial pulse. Remember, in case of a chronic MR, I'm talking of chronic and acute separately here. So in case of a chronic mitral regurgitation, say a chronic primary mitral regurgitation, so in this case, the arterial pulse is usually normal. Okay, usually normal until say late in the disease course. Because see, here the LV ejection time and the forward stroke volume is relatively normal, which is why I can say that the arterial pulse is normal until the late stages. However, if you're talking of an acute mitral regurgitation, or maybe even a end stage chronic severe MR, okay, or a end stage chronic severe MR, especially when there is a decompensation. Now, in this case, what is going to happen is there is a rapid reduction in the forward volume of blood, correct? The forward volume or the effective stroke volume is less, along with a decrease in the ejection time. So what will happen is the arterial pulse will fall off rapidly, giving the impression of a bounding pulse. Okay, you can have a bounding pulse. So what happens is in this stage, there is a rapid reduction in the forward blood flow. There is a decrease. Along with this, there is a decrease in the ejection time, because of which there is an abrupt fall off of the arterial pulse, and this gives a bounding pulse impression, which is very similar to that of which other condition? Aortic regurgitation. Okay. But remember, one very important differentiating feature is that in case of mitral regurgitation, the pulse pressure is normal. Okay. Whereas in case of aortic regurgitation, you will have a wide pulse pressure. Okay. You will have a wide pulse pressure, whereas in case of a mitral regurgitation, the pulse pressure is normal. So this is about the arterial pulse. You should know about the chronic MR versus the comparison of acute MR and end stage chronic severe MR. Now coming to the blood pressure, BP. So BP, remember, in mitral regurgitation is usually normal. Okay, usually normal. Okay, unless you have other coexistent valvular heart disease or maybe some other cardiac illness. So BP is usually normal. Okay. Coming to the next finding, what about the apex beat? Okay, what about the apex beat? Well, apex beat in case of your mitral regurgitation, remember, you will have a brisk and a hyperdynamic apex beat. Okay, you are going to have a brisk and hyperdynamic apex beat in case of mitral regurgitation. Brisk and hyperdynamic apex beat. Okay, all right. And also remember, the apex beat, the position is also changed because there is a LV enlargement, the apex beat will be displaced to the left. Okay, so the apex beat will be displaced to the left. Okay, you have eccentric hypertrophy that is happening. And on palpation, over the cardiac apex, you are going to have a systolic thrill. Yes, you are going to have a systolic thrill, which you can palpate over the cardiac apex. So these are some important examination findings. And let's move on to the auscultation findings. Again, hot favorite for the exams, but very simple also. Auscultation. So auscultation finding, we'll go systematically. First, let's discuss about the S1 in case of a mitral regurgitation. Okay. See, S1, if the patient is having a significant MR, okay, let's assume if the patient is having a significant mitral regurgitation, so in such a case, you are going to have a soft S1. Okay, you're going to have a soft S1. And this is especially true if there is a RHD-MR. Okay, especially true if there is a RHD-MR, you are going to have a soft S1. And many a times, the S1 will be buried in the murmur of the mitral regurgitation. We will learn in due course that it is going to be a pansystolic murmur. So the S1 will be buried in the pansystolic murmur. So I told you what you're going to get is a soft S1. The question is, can you have a normal S1 in case of a mitral regurgitation? Answer is yes. So one is if it is a mild MR, if it is a MVP MR, and also you can have if the MR is due to a papillary muscle dysfunction, okay, MR due to papillary muscle dysfunction, then also you are likely to have a normal S1, okay, papillary muscle dysfunction, okay. So that is about S1. Now moving on to S2, okay, what happens to second heart sound, S2. So remember, if the patient is having a severe mitral regurgitation, okay, let's assume it is a case of a severe mitral regurgitation. Now what can happen is the aortic valve can close prematurely. So why does the aortic valve close prematurely? It's because of the reduced forward cardiac output. So there is a premature aortic valve closure. Okay, there is a premature aortic valve closure, right? There is a premature aortic valve closure. And because there is a premature aortic valve closure, I'm sure you have heard of the A2 and P2 components. So what happens is there is a wide split of the S2. Okay, wide split of S2. Okay, but remember this is only in case of a severe MR. This is very, very important. But remember, if the patient is having a significant pulmonary hypertension, the P2 component is actually loud. Okay, so talking of the S2, you can have a loud P2 component when the patient has a pulmonary hypertension. Okay, pulmonary hypertension. So this point you should know. Coming to S3, third heart sound. Okay, coming to S3. So S3 in case of mitral regurgitation, remember it's a common finding to have a low pitched S3 in case of MR. Okay, you will have a low pitched S3. So why do you have a low pitched S3 in case of your MR? Is because, see, in case of mitral regurgitation, there is an increased flow across the mitral valve. So there is an increased flow across the mitral orifice, especially during the rapid filling phase. So at the end of the rapid filling phase, there is a sudden tensing of the papillary muscles and chordae tendineae, which gives rise to the S3 or the third heart sound. Okay. But one point you should know is that, this is a very important question, S3 per se in MR is not a sign of heart failure. Okay. What did I say? S3 per se in MR is not a sign of heart failure, except say it is a case of a ischemic or a dilated cardiomyopathy. So in case of a ischemic or dilated cardiomyopathy, then the scenario is different, where an S3 can indicate ventricular dysfunction. But otherwise, remember, in case of mitral regurgitation, the presence of S3 is not a sign of heart failure. It is a part of the hemodynamics of mitral regurgitation. Okay. Now, if there is a patient with a mitral regurgitation who is having an S3, I can be sure of two things. One is the MR is severe. Okay. MR is severe. And see, many of the cases of MR may be associated with MS. So in case there is an associated MS, this S3 is unlikely. So if there is an S3, I can also make a statement that a significant MS is unlikely. Okay, significant MS is unlikely. Okay, so I can be sure of these 2 points. So S1, S2, S3, these 3 very important. Now, remember in the auscultatory findings, the most characteristic and prominent auscultatory finding in case of MR is the PSM, that is the pansystolic murmur of chronic severe MR, which is almost always present in case of significant mitral regurgitation. Remember, this is a pansystolic murmur with a minimum grade of 3 out of 6. Okay, minimum grade of 3 out of 6. And always remember, this murmur is best heard with the diaphragm of the stethoscope. and the patient is placed in the left lateral position. So best heard with the diaphragm of the stethoscope with the patient in the left lateral position and the diaphragm placed over the apex beat. Diaphragm placed over the apex beat. Okay. Now, why is this murmur pansystolic? Okay, so this is a pansystolic murmur. So suppose this is S1, this is S2. So you're having a pansystolic murmur. Okay, pansystolic murmur. So why is it pansystolic means just after the S1, the left ventricular pressure will exceed the LA pressure. So the regurgitant blood or the regurgitant jet of blood goes from the LV to LA because of the pressure difference. And this flow, because of the pressure difference, continues to and into the S2 until the LA pressure exceeds the LV pressure. Because as long as you have the pressure difference, there is a regurgitant flow. And because it is constant, this is why you get a pansystolic murmur or a holosystolic murmur with the same intensity. Okay, holosystolic murmur with the same intensity. So remember the nature of the murmur that you have associated with the mitral regurgitation is of a blowing high-pitched nature. Okay, this is a blowing high-pitched murmur. Okay, blowing high-pitched murmur. And this is, as I told you, this is loudest over apex. Loudest over apex. And in this murmur, there is a frequent radiation to the left axilla and left infrascapular area. Okay, there is a radiation to left axilla and left infrascapular area. Now, such a radiation to the left axilla and left infrascapular area is more with the posteriorly directed jets. Okay, is more with the posteriorly directed jets. See, what happens is, MR, can be because of an anterior mitral leaflet problem predominantly or a posterior mitral leaflet problem. So if it is predominantly involving the anterior mitral leaflet, this is a posteriorly directed jet. However, if the MR occurs because of a posterior mitral valve leaflet abnormality, in such a case, okay, so let's see that case where the MR occurs because of a posterior mitral leaflet abnormality. Okay, posterior mitral leaflet abnormality. See, in such a case, what happens is the murmur can radiate to the aortic area or sternum. So there, in that case, there is a radiation to aortic area or even the sternum. Okay. So this is because in case of the posterior mitral leaflet involvement, you will have an anteriorly directed jet. Okay. Anteriorly directed jet in contrast to the posteriorly directed jet. So here it strikes the LA wall just adjacent to the aortic root, because of which you will have a murmur radiation to the aortic area or the sternum. But remember, in case you have an MR because of a posterior mitral leaflet abnormality and a radiation to the aortic area, which other murmur are you likely to confuse it with? Aortic stenosis. You are likely to confuse with the murmur of aortic stenosis, which is a ejection systolic murmur, but you may get confused. But remember, aortic stenosis murmur always radiates to the carotids, but here the MR murmur, because of a posterior mitral leaflet abnormality, does not radiate to carotids. Okay, does not radiate to carotid. Okay, all right. So it's a pansystolic murmur, holosystolic murmur, the nature of the murmur, the difference when it occurs because of a posterior mitral leaflet abnormality, I have discussed them all. Now, another feature you have got to know about the pansystolic murmur of mitral regurgitation is that, see, when you have LV volume increase, when you have an increase in the LV volume, the murmur also becomes loud. Okay, you will have a louder pansystolic murmur. So, which means, say, if the patient is having a heart failure or the patient is lying down and there is an increase in venous return. So, or maybe even a condition where the arterial pressure increases, as in case of squatting. or a isometric hand grip exercise. So all these conditions, you can have an increase in the LV volume and an increase in the loudness of the PSM. Okay. Now, when there is a decrease in the venous return, for example, if the patient is standing, or in case of patient is performing a Valsalva, so standing position as well as Valsalva maneuver, in these cases, what is going to happen is that there is a decrease in the intensity of murmur. Okay, there is a decrease in intensity of pansystolic murmur. Okay, all right. And another very important MCQ about, again, this pansystolic murmur is about the relationship between the PSM and the severity of MR. Okay, severity of MR. Please keep in mind that there is no correlation between the intensity of, okay, there is no relation between the intensity of pansystolic murmur and the severity of MR. Okay. Now, one more MCQ you have got to notice. I told you the murmur is usually hollow systolic. Okay. But in case of an acute severe MR, in case of an acute severe mitral regurgitation, in such a scenario, the murmur can be a decrescendo murmur. Okay, so you can have a variation in case of acute severe MR where the murmur is a decrescendo murmur and stops in a mid systole to late systole. Okay, stops in mid to late systole. Okay, that's what happens with an acute severe MR. Now, if the MR occurs because of a caudate tendineae rupture specifically, then the systolic murmur can have a cooing nature, okay, a cooing nature or a seagull quality, cooing or a seagull quality. So this occurs in case of a MR because of a caudate tendineae rupture, okay, caudate tendineae rupture. So this often happens when a patient develops a mitral regurgitation in the context of a subacute bacterial endocarditis. So that is when you can have a rupture of the caudate tendineae, and this is called a seagull murmur. Okay, seagull murmur, okay, or a cooing dove murmur. Seagull murmur or a cooing dove murmur. These points are important. And next, regarding an entity, again important, which is called silent mitral regurgitation. Okay, so what is this silent mitral regurgitation? So in some cases, the systolic murmur may not be much audible. So what is the scenario in which you are going to have a silent mitral regurgitation where you have a inaudible or maybe even an absent pansystolic murmur? So this happens when the mitral regurgitation occurs, a severe MR occurs because of a LV dilation. Okay, a severe MR because of a LV dilation, a severe MR because of an acute myocardial infarction, a severe MR occurring in a patient with a marked emphysema, maybe even I can say significant obesity, okay, even a chest deformity as well, chest deformity, and sometimes occurring in the context of a prosthetic valve. So in these scenarios, you may get a silent MR, okay. And also remember, mitral regurgitation patient, in addition to a pansystolic murmur, you can have an apical mid-diastolic murmur, apical mid-diastolic murmur. So this happens because, see, there is an increased flow of blood through the valve in diastole, which is producing a low-pitched mid-diastolic rumbling murmur, and this is referred to as a functional MR. Okay, you can have a functional MR which resulting in a apical MDM murmur, which occurs because of an increased flow through the valve in diastole. Okay, Next, the last point about the examination is about how to assess the severity of MR. So assessing MR severity via examination, okay, via clinical examination. So number one is the presence of an apical MDM. So if you have the presence of an apical mid-diastolic murmur, it is again showing it is a severe MR. If you have the presence of LVS3, we already discussed this. This is a severe MR. And also if you have a degree of LVH, okay, clinically when you assess, significant LVH again points to a very severe MR. And also over the apex, if you have a systolic thrill over the apex, okay, if you have a systolic thrill over the apex, that also is going to show that the MR is a severe one, okay. So these points you have got to keep in mind about the examination findings in MR. You will get very simple but basic questions. Do not get them wrong, okay.